Sarah Levant, and I'm so glad you're here. Here at Bundlebirth, we believe that your life has the potential to make a deep, meaningful impact on the world around you. You, as a nurse, have the ability to add value to every person and patient you touch. We want to inspire you with the resources, education, and stories to support you to live your absolute best life, both in and outside of work. But don't expect perfection over here. We're just here to have some conversations about anything birth, work, and life, trying to add some happy to your hour as we all grow together. By nurses, for nurses, this is Happy Hour with Bundlebirth Nurses. Being a labor and delivery nurse is so amazing. It is, we always talk about like we're part of the miracle, we're part of the magic, we get to shape the future. And there's also this layer that we have to manage of the stressful part of our job on top of just the stressful part of the safety things that we see and the complications and the emergencies and the bereavement cases, et cetera, et cetera. And then you layer the legal on top of that, which adds this, it feels like a dark cloud at times. I know as I went through nursing school and as I, especially early on in my practice, it was this constant like, well, but my license, and I don't want to lose my license, and this license and legal being thrown around left and right. And then when we look at the medical system and we talk about why people are making the decisions that they are and why we have the current state of obstetrics that we do, there's always this layer of, well, we're trying to avoid liability that comes up. And so today I am thrilled to finally, it's about time, invite Pam here. Pam Hetrick is here to discuss all the legal things and answer some of our questions and hopefully sort of just like settle our nervous systems, because if you don't know already, you may, and some of you may recognize her voice because Pam partnered with us with our mentorship program. So we have a 12-month mentorship program, and in that we brought in Pam to discuss the legal side specifically of fetal monitoring. And she has a deposition and trial class on our site that when we brought her in for mentorship, we were like, can you please just help us? Because we're all afraid of getting sued. And if you are deposed, I didn't know of anywhere to go that would help me really prepare in a safe environment of my home, know what to say, what not to say for that deposition. And or if you're worried about it, just know that class is there, it's available, and Pam teaches it. So it has been years since we met. I don't know, I don't even remember how we met. It was maybe social media, which is usually how it happens.
It was.
And so now she's finally here for the pod to discuss all of the legal things. So Pam, why don't you give us just a little introduction about who you are, what you do,
Sure.
what your current role is, past role, where you've been, and then why you're equipped to talk about this legal stuff.
Okay. So as you said, Sarah, thank you so much for inviting me here. I am Pam Hetrick. I am a certified nurse midwife, and I have been in obstetrics for a crazy 30 years. And I started out as a labor and delivery nurse in a unit that was fairly new, that took a hodgepodge of all people in the city of Cleveland to form. And it was such an amazing group, but looking back, it was a really high liability. And look, we're all here still with our nursing license. And then I became a nurse at another institution. Really found a passion of midwifery with being able to have the relationships with patients for years and years and years. And so I became a midwife in 2003. So it's 23 years ago. And since then, I have practiced full scope midwifery. I am a nursing, or I should say, I'm a midwifery and advanced practice leader at my organization now. So I have about 70 advanced practice providers, and drum roll, in 20 days, I will have my DNP, and that
What?
feels, yeah, 20
Stop
days. I get
it.
my, no, I get my
Oh
DNP
my
in
gosh,
20 days, and
congrats.
I'm really excited about that. And so, how did I get into this whole thing of expert witnessing? So, I didn't bring that whole thing up. So, when I was a baby midwife and I was, very well skilled as a nurse, I worked with a midwife who had a pretty prolific expert witnessing business, and she had just finished doing labor and delivery. And she really did not want to lose this lawyer. And so she said to me, hey, I've got this RN case and it's pretty much a slam dunk. I can't take it, but will you take it and I'll walk beside you on how to be an expert witness? And I said, I have no clue what I'm doing, but I will follow your lead. And so the birth of Hetrick Consulting LLC started in 2004, and I have been actively reviewing lawsuits. Primarily now, I have some attorneys that have had me for a long time, and so they'll call me even for a nursing case just to say, take a look at this, let me know what you think. But I primarily review for midwives now, and the plaintiff and the defense side. So the
Mm,
people who are suing and the people who are defending. And it has really strengthened me as a healthcare provider with knowing that sometimes we take absolute perfect care of patients and bad outcomes happen. And you
mm,
are not a bad nurse and you are not a bad midwife or nurse practitioner, or physician's assistant, whoever's listening to this. And then sometimes there's stuff that everything um, does go wrong, and I look at it and wish that the documentation would have looked better. But
mm,
everybody fears their license, and no, unless you go to work with the intent to harm, your nursing license is pretty much protected. And I guess that's what I would love to talk about today is that we're in a really hard spot in healthcare right now with patient care because they get a lot of ideas not from great sources on social media and they show
yep.
up. And what do we do? What do we do for the patients who decline everything? What do we do for the patients that we don't think are getting proper consent? What do we do
Mm-hmm.
about chain of command? So those are all of the things that I think are important to talk about. And the other thing is, knowing that when we're caring for patients, the way that we protect them is that we think about, are they being heard and are they safe? And most of the time, if the patients feel safe and heard, you're going to avoid litigation.
Mm. Say that again.
Safe and heard, right? Are you at the bedside advocating for the patient to be heard? So that means when they don't feel comfortable with what a provider has talked to them about, or they feel like they are being pushed into one intervention or an intervention that they don't want, are they being
Mm-hmm.
heard? Are you huddling at the bedside? Are you bringing the provider back in? Is the patient being told about the risk benefits and alternatives of anything that we are recommending for them to have? And so a lot of this is increasing your communication at the bedside with the patient, that the patient understands and that the provider and the nurses are all on the same page.
Mm-hmm. So you're saying that if I build my skills in specifically shared decision making, meaning that we as the care team, probably doctor, midwife, has a recommendation, patient listens to it, and there's some sort of hesitation, we stand in the gap and we help them be heard, that we ask them those questions, we slow it down, we advocate to the doctor, hey, this is what I'm hearing, seems to be important to them, that in itself is going to help you avoid litigation.
Let's think of the patient that comes in that is going NCB and is in transitional labor and they're all over the bed and you can't monitor that patient, right? And you're putting your hands on the patient's belly and maybe you've got a little bit of a concern like, I think I heard a variable, or is this maternal, or what it is, and the patient's like, get your hands off of me, don't touch me. And so the nurse is like, okay, I'm not going to touch you. But in the back of your head, you're
Yes,
concerned. You're like, I don't really know what's going on.
this is such a good example.
Instead of just writing patient refuses, or I personally like declines better. Hey, Mary, I you're doing such a good job, but I really need to make sure that your baby is okay. I can't tell if your baby is not okay if I can't get your baby on the monitor. Okay, that's kind of explaining to her what your
Yep.
concerns are. If she says, go to hell, I don't want you to touch me, then you say, I'm not sure if your baby is okay. and she still says, I don't want to be touched, you can say, discuss the risks and the benefits of me putting her back on the monitor. And you're going to call your provider and say, get in here. But the patient might say, oh, I didn't know that they were concerned about the baby. Okay, go ahead and touch me, right?
Mm,
But it's a little bit like, think about expanding it a little bit more. Your patients who are declining an IV, or your patients who are declining vitamin K for your baby, because I know that we're
hmm.
seeing a lot of that right now.
Yep.
Do they understand the risks of what they decline? And if you are writing in there that they understand it, you can't do anything else, because then you're kind of, it's basically assault, right?
Hmm. Yep.
So it's just really important for the patient to understand what your concern is. So I would say that is one of the biggest nuggets that I'd like to put in your head now, is just making sure that you add that into your note. You might have
Yep.
said it, just add it into your note, or just verbalizing with the patient.
And what would your note sound like?
Patient uncomfortable, like, let's just take Mary at 8 centimeters, rocking and
Okay.
rolling in active labor, monitors flipping all over the place because she's all over the
Hmm.
bed. Just difficulty with obtaining fetal monitoring strip, secondary to patient discomfort. Discuss with patient need to place baby on the monitor to assess fetal well-being. Patient continues to decline. Provider notified and asked to come to bedside. That's it. Or patient understands, we'll get, we'll get baby back on monitor at this time.
Hmm. If you saw that in the chart, you'd say they did their thing. Okay.
Correct. They did their thing. Same with an IV. You might be the best person on the unit to throw in a 18 gauge in somebody's anacube, but we all know how quickly things can go awry when you've got a postpartum hemorrhage and the best person on the unit can't get a line in them. So just talking like that, the patient understands the risks of not having IV access, just a saline lock, in case of an emergency, and you discuss those risks. And it should be a part of what your provider
Hmm.
hopefully is doing too. But it also will allow somebody that's coming in to review the case, an expert, to say, wow, this nurse really, like, this was a well thought out note that she talked to the patient about the risks and the benefits of doing this, and the patient still declines. It kind of shows that forethought that the nurse was acting as a prudent person would at the bedside.
Hmm. I think when I'm thinking about these scenarios, I think the fetal monitoring one is so good because we all are so sitting stressed and a bundle of stress about like, oh my gosh, I can't see it, I can't see it, I can't see it. And you're wanting to touch them and they're yelling at you not to touch them and you don't want to touch
Mhm.
them because they're saying not to touch you and all of that. So if we take that example, I can just picture in my mind the fact that I'm picturing that you have no tracing, like just blah, like little dots here and there across. And obviously things are moving, but this baby comes out depressed and needs resuscitation. Let's say it needs cooling, God forbid, but it needs cooling. That I just like I can hear the conversations at the nurse's station saying, well, I'm gonna get sued. Or
Mhm.
anticipating a bad outcome, not even going to a bad outcome, right? But anticipating an outcome like that. And the conversation at the desk being, well, but you have to cover your license, but you have to cover your license, which means you have to do what you want to do to make you feel comfortable, regardless what the patient is declining. So,
Correct.
what would you say to that argument? Because I think there's like a cultural environment that we work in that sort of is the covering your license. You want to do what you feel is best as the medical professional, which from a medical standpoint might be safer. But
Right.
ultimately, what we're toying with here is the autonomy over their body, is the self-efficacy, is, all of those ethical, legal considerations and which one stands, especially in the case of of a bad outcome.
Yes, there's always the talk at the nurse's station, I'm going to get sued for this, right? But the other thing is like, just picture this, is that you do have a bad outcome. How important it is to still huddle at the bedside with the patient afterwards to explain the sequence of events.
Mm.
That should be a no-brainer. It should be happening all the time. If you have a poor outcome, that the provider and the
Mm.
nurse and anybody else that was there, the charge nurse, the baby nurse, whoever it is, huddles at the bedside, and first you provide empathy. I am so sorry that this happened, but let's go over what we saw, what happened, um, that caused this kind of outcome with your baby, right? And you
Hmm.
sit there and you talk through the patient, because the one thing it's shown over and over that a lack of communication to the patient is usually the number one reason, or the relationship that the patient has is usually the number one reason that they decide to sue.
Because they're
Everyone's
pissed.
kind of right.
They feel
Everyone's
alone.
running away, right, from what happened. And sometimes we don't see bad things that are going to happen. Sometimes,
Hmm.
it's the patient that wouldn't let us monitor, and it comes up in that debrief that was like, you remember when we were having difficulty monitoring your baby, and we talked to you about that, we were concerned about the well-being of the baby, and then all of a sudden, we saw a bunch of blood and the baby came out, and the baby went to the warmer and the pediatricians worked on the baby, and it's just basically in the moment talking to the patient about the sequence of events that happened prior to the birth or the
And
outcome.
that's legally like recommended from a legal standpoint.
Yeah, absolutely. I mean, a
Mm.
shoulder dystocia, a hemorrhage, anything like that should be anything that's, I shouldn't say out of the ordinary, should be debriefed at the bedside with the patient.
I was thinking back to when I was a brand new nurse. I'd have these patients who would just not progress. No matter what I tried, they were stuck. I finally would go on break, and that one experienced nurse, you know which one it is, took over for my break. And by the time I came back, the patient was complete, which is amazing, yes. And I'm so grateful for them. And it was also so frustrating to feel that helpless, to not know what to do, and then ask, "What did you do?" And they actually can't tell you. If you know me at all, you know that I get obsessed and cannot stop until I find all the answers. And this one got my brain going. I wanted to figure out what the heck so many of our experienced nurses were doing, and more importantly, to finally understand the body in a way that we are never taught. I wondered if there were things I was doing that could either help or hinder the labor process. And by the way, I learned there is. I wanted to equip myself with tools I could use with my hands tied at the bedside, well, both as an L&D nurse, but especially now when I'm attending births as a birth coach and my hands are tied. I'm not able to titrate the pit, I'm not able to call the doc for interventions, and I'm relying fully on the physiology of the body to help labor work. And after reading hundreds, if not thousands of resources out there and putting in thousands of hours of work, I figured it out. And I want to give you that too. If you've ever felt helpless, hopeless, or alone in your practice, you are not the only one. More than 7,000 nurses have now taken our physiologic birth class, and they describe feeling energized, empowered, and equipped for their very next shift. They walk away with practical, repeatable tools they can use with every patient. Not a one-size-fits-all prescription approach, but the ability to critically think your way through any birth scenario. A way to look at the body and know exactly where to start. You can activate physiology and optimize the systems that actually make labor work. Together, we can change the game in obstetrics. So if you're ready to feel confident instead of stuck, equipped instead of overwhelmed, and connected to a community that is committed to excellence, knowing that you're not alone, join me at our next physiologic birth class. It's truly a masterclass for every nurse to apply with every patient. Link is in the description. I can't wait to see you there. I love that because we talk about this with our trauma-informed care stuff when we're teaching about trauma-informed care and we're talking about the birth memory and the birth experience. And it sort of feels culturally kind of like you're pulling somebody's hair to like come just have a conversation with them. We're human. So much of
Mm-hmm.
this is human. And yet another angle to promote that bedside debrief is for your own legal protection. And
Yeah.
and the patient benefits as well, especially if you're doing it in a way. I'm just picturing, I think It's also important to acknowledge that there's a way to do this in a way that you're not blamey and that you're also not coercive when you're having these conversations, that it's an objective, lay out the information. This is what I'm concerned about. But then there's also the layer of, I think we personalize a lot
Hmm.
their decisions and we say like, well, but, and like, and then we judge. And then that potentially changes our subsequent care with the patient because you're like, I love you actually like implied this of like, instead of just, oh, they're refusing and they're out of control or they're yelling and like, oh, they like snapped at me and I'm offended, that instead you objectively say, okay, my job is to make sure you understand what you are declining and what that
Correct.
could mean for you. And so you know that that's your role. And if you have done that, you document it in the chart objectively, and then you follow up as things change. That if you were to end up and you debrief afterwards,
Hmm.
that if you were, first of all, your chance of being sued is so much less likely. But if you were, that somebody like you who's reviewing the chart as an expert witness would look at that chart and go, wow, they did the reasonable and prudent thing in
Hmm.
within their scope, and ultimately it's on the patient because they declined.
I mean, just think about this. Think about a patient that, might have had prior trauma, like sexual trauma, whatever, and everything, the birth goes fine. And then all of a sudden you've got a retained placenta, or the patient starts hemorrhaging. And you think about all of the things that, you see as the nurse. You're seeing sometimes the provider's hand is going into the uterus to either remove the placenta or to give bimanual compression. We're sticking things up patients' butts, giving them the
Mm-hmm.
Cytotec. All of that stuff is going on, and the patient's like, "Holy cow, this is so traumatizing. What are they doing to me? Nobody's talking to me." Like,
Yeah.
and that's one thing is when the room is kind of chaotic, is if you have that one person that's able to say to the patient, this is what's going on, this is why we're concerned. That debrief at the end is so important. Like, this was
Mm-hmm.
really, really scary that all of these people came in the room and that you were bleeding heavily, but this is what we did and this is why we did it
Yep.
to help, you know. We have to remember those debriefs are so important.
So this brings up a point because one of the ways that I feel and have felt, no, regardless my role as a nurse at the bedside, when there's a provider at the bedside. So let's say everything goes perfect, they're hemorrhaging, they have their hands inside and they're calling for the cytotech and placing the cytotech and no one's talking to them. One of the awkward places I know I've been in a million times, and I know that many of us have been in, is when the provider isn't sharing what's going on. And I can
Hmm.
imagine, I'm not a provider, but I can imagine that it's stressful. And I know for
Hmm.
me, when we're in stress, we know this from a physiological standpoint, our Broca's area, which is our speech, goes down, it goes dark. And so it's easy to be like, and you don't really know what to say because you're stressed out. What I've heard and understood is that it's also not my job as the nurse to provide the information about what is going on and what they're seeing. So if I were to say, you're bleeding too much, we're placing this now, their hands inside for this reason, cytotech for this reason, that really needs to come from the provider first. And once it has, it sort of, like I imagine, it sort of like opens up the floodgates. I actually talk about this in our Live Colorfully class, by the way. So please feel free to join us because we talk all about shared decision making in this. But I'm thinking about those roles. And so once the floodgates are open, then I can follow up with my nursing education and sort of like supplement. And how does that sound? And oh, here's another way of thinking about it kind of conversation, right? And so,
Yeah.
what do you suggest for us as nurses when we're in those awkward moments? We're trying to support, we have that standpoint, not as the provider, but no one's talking to them and explaining what they would do. Now, mind you, as a doula, somebody that functions as a doula who's lowest on the totem pole and very much not allowed to speak to anyone but the patient or else, I've been in those scenarios. And one of the things that I just say, and luckily it's me, and people typically now I can get away with a little bit more because of who I am, and people know I'm a nurse, but I would just say, does someone want to explain what's going on?
Yeah.
And yet that takes some poise because if they're truly bleeding out and the Jada's coming out and they're starting second lines and it's chaos, like how reasonable is that? et cetera, et cetera. So what advice do you have for us? Because us as nurses, this is so
Mm.
awkward.
Yeah, I mean, definitely. I mean, I think that, saying to the provider, can you just at least explain what's going on? And I don't think that any provider is going to say, Sarah, be quiet. If,
Yeah,
if I said,
as long as I'm
Mary,
not the doula.
as long as you're not
Kidding.
the doula, right? Right. Hey, Mary, I need you to look at me right now, right? Like the patient's got her eyes closed and everything. Mary, I need you to look at me right now. I need you to listen to what we're saying. There's a lot of stuff going on, but uh, Dr. Smith is right now, we're concerned because you're bleeding. And as soon as he gets things stable, he will tell you what's going on, right?
Hmm.
And then also, please, 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 please remember the significant other in the room
Hmm.
who is watching all of this go down in absolute horror and
Yeah.
trauma that they go through. Like sometimes I think like, oh, these poor support people that are watching this, like
Yep.
we're doing something right. They're sitting there watching it, like maybe holding a leg, like what in the hell is going on here, right? So
Hmm.
always remember to, if you've got a resuscitation of a baby that was unanticipated and you've got somebody from the family there, is to keep them updated, kind of going back and forth and saying the pediatrician will be over to talk to you as soon as possible. But this is what I see that they're doing for your baby right now.
Hmm.
Kind of increases that communication back and forth too, that they don't feel scared and they don't feel excluded. Same with, and I know I'm digressing a little bit, but remember like your urgent sections that are going back, or
Yep.
your individuals who hemorrhaged and you take them back to the OR, how important it is to have somebody on the floor be the go between the patient and her family in the room to make sure that they feel again seen and heard.
Mm. And that now I mean, all of this is like good care. Like this is the
Right,
proper thing to do as a human,
right,
and it's legal protection.
right.
Why not? We'll continue to monitor.
A lot of things that I will see on charts, and it literally can make me batty, is when like things are going not well. The
Yep.
strip is terrible. I mean, I don't want to say terrible. You've done your intrauterine resuscitation. You're rolling the patient. The variables are still deep, and you call Dr. Smith and it's 2 in the morning, and he's been in clinic all day and he's tired and he's got surgery, the huge that we hear. And I will see Dr. Smith aware, no new orders received. And I'm like, okay, Dr. Smith, I need you at the bedside right now. Requested Dr. Smith to bedside. Dr.
Mm.
Smith says it's okay. That is where you, as the nurse, have the responsibility of saying, I'm activating my chain of command. Now, if I see this and, Dr. Smith aware, requested a bedside, states uh, reassess in 30 minutes, and you say to him, I'm activating my chain of command, that shows me again forethought, right? Like, I
Mm.
know that something is not right. I need to get somebody else here to the bedside. So you call your charge nurse, and then the charge
Would you
nurse calls. Go ahead.
would you say I'm activating chain of command in your
You
note?
sure can. Oh, you
Huh.
absolutely can.
Okay. Keep going. Sorry, I had to
Yeah.
ask that. I'm like,
No, no,
really?
no.
So then, okay.
No,
So
you can
then
put
I'm
that in there,
activating
right?
chain of command so that it clearly delineates that the provider is aware that you are not satisfied with their response and you need more help, but they're not responding.
Correct.
Okay.
And
All
you
right, keep
you
going.
know something's wrong, right? Like,
Mm-hmm.
we talked about it when people go out, and this is kind of a cultural thing on some of the units where people are like, I'm working with so and so today, and she doesn't want to hear anything that a nurse has to say, right?
Yep.
And so something's going on, you're like, I'm totally getting sued. My license, I'm
Mm.
going to lose my license and I'm going to get sued. And it's like, okay, but somebody at that desk has to say, there's an attend, like, let's just say it's with a midwife. There is an attending on, right? And even in states with independent uh, licensure for advanced practice providers, we still have to have a physician. So
Mm-hmm.
you call the physician. And let's say that, I mean, if we actually had it, there is years ago, and I'm going to tell this person to listen to this podcast because she's going to sit there and smile. I was a fairly new midwife, and this patient's strip looked horrible. And it was a family medicine provider that was managing this labor. And this individual was the assistant nurse manager, and she's pacing back and forth. And I said, you know what you got to do? Print the strip off, and we're going to send it to our department chair and our
Mm-hmm.
department chair. So we activated the chain of command, right? It went from the charge nurse to the assistant nurse manager. And then we went above that person and we went to the department chair. The department chair called the board attending physician and said, you need to go in and you need to tell them that you are sectioning this patient now. The
Mm-hmm.
strip is bad. And so this was probably a good 20 years ago. She brought it up at a leadership conference that we were at about like
Mm.
sometimes as the leader, you have to make uncomfortable decisions for patient safety.
Yep. And hopefully you have leadership support that when you do that, that your leadership can see your intention that I'm concerned. And that's what comes back to that. Like cuss,
Hmm.
I'm concerned, I'm uncomfortable, this is a safety issue, rather
Hmm.
than so much personalization and drama and like, oh, well, you like, what do they think? They think that I am trying to keep the patient safe. And that's where, for
Right,
me personally, that's very grounding for me when I'm in those scenarios that I'm like, I could come across, quote unquote, a certain type of way. And the question for yourself is that like, am I doing this because I have a vendetta or because I have a personal preference
right,
that I'm trying to push?
right.
Or am I doing this because I have a safety concern and it is my job to keep this patient safe and stand in that gap? And if it is the latter, then you're in the right, no matter whether you have leadership support or not. And so, and
Yeah, I
hopefully you
mean,
do. Hopefully you do.
right.
But
And you know what? I could just say this. Don't be the nurse that, is submitting past reports left and right because of just very minuscule things. Be the
mm-hmm,
nurse that is able to say, this is unsafe. I don't feel comfortable with this. And then doing what is right.
mm-hmm,
And you know what? I actually just took our compliance training, and it talks about like if you have, if your fear of retaliation, which that's I would say 98% of it, people don't want to act up because they're feared of retaliation, but you have protection against retaliation in a situation like this
mm,
because you did the right thing. Your culture at your organization should be one that you're able to speak up, and that managers are going to have your back in a situation like this when you rang the bell.
yep. What other tips do you have for us?
I talked a lot about declination, and I just have to say, I feel for you guys at the bedside because it has to be very, very frustrating when patients are trusting an influencer
Mm-hmm,
over science. So I want to first say I applaud you for what you do. It's super hard work.
mm,
Consent. Another thing is making sure that the patient has given consent for things like breaking water, vaginal exams, placing a balloon, right? Like not a provider coming in and saying, "Oh, let me check your cervix and let's see what's going on. Oh, it's good. Can I have the hook now?" It's like, wait a minute here. Did we talk to her? Is
mm-hmm.
she consenting for this procedure? Some of the harder ones that I've seen in my lifetime is we had a patient who physically walked in the hospital after like a 7-hour second stage at home, and actually had a posterior uterine wall rupture because the
Ooh.
labor was so obstructed. And the
Oh.
patient came in and they tried to put monitors on, and she first declined, and the baby looked category 3-ish.
Mm.
And the patient declined to go back and have a section, and
Yeah.
everyone was up in arms about it. But I said, did you discuss with her the risks of brain damage and death of her baby? And they said, yes. And I said, that's all you can do right now. You can't do
Yeah.
anything else without the patient's consent. And for us, it's like, how could she do this? But again, the patient has autonomy over herself and her body,
Hmm.
um, to
In
make
most
those
states.
decisions. And it's not what this, I mean, I think part of the hard part is it's not the decision that we would make for ourselves, but we
Yep.
have to respect that if she has been adequately counseled,
Yep.
she has the
We
right.
we talked about this at Move, and it's coming in the Live Colorfully class, y'all. So that class is like such a fun little hodgepodge of a lot of this stuff, but the shared decision making part, the coercion, the misinformation, all of that. And one of the phrases, one of the scripts that we talked about at Move and will come up in this class is simply, I respect that. That if you get to a place where you've had those conversations and you know that you've done it in a non-coercive way, that and they're still declining, the answer is I respect that because I respect you as a human being that you are, that has different
Mhm,
preferences, that has a whole different history that I will never fully understand. And sure, it
mhm.
may not be the decision that I would make, but I'm still here to offer you the care that you will allow me to give you, and I'm going to respect you and respect that decision along the way. But that's hard, man. That's
Yeah,
hard. What it becomes though is, well, I'm scared of my license. And what I'm hearing is that if you've done that, you really don't have anything to be afraid of.
correct. I mean, literally in my 30 some years of having one form or another license in Ohio, registered nurse in advanced practice. I mean, I've heard of people having their license taken away for drug diversion. That's
Mm-hmm.
pretty simple.
Clear.
Do I ever know anybody, honestly, that had their license taken away for unsafe practices? I don't.
Mm.
I mean, you hear, where was it over in Europe, in England? They had a nurse that was going in and hurting babies in the NICU. That person, yes, that was with
Sure.
intent. She did that.
Yes.
Should she lose her license? She absolutely should.
Yeah.
But, I have never, I mean, I've seen some pretty horrific cases over my 22 years of doing expert witnessing work. Like, I'm like, how is this the United States that this is the care that this patient was provided?
Mm-hmm.
Those individuals did not lose their license.
Mm. I think that's good level setting and good, like, for our
Yeah.
nervous systems.
Yeah.
You know,
Absolutely. I
because
mean,
and none of us
you,
want it. It's still embarrassing, sure. And
yeah.
you end up deposed, and you will likely get deposed at some point in your career. It's sort of just a part of it. And when you do, come take her deposition and trial class, because I remember taking it
Yeah.
and being like, oh, depose away. Like, I got this. It was
Yeah.
very, very reassuring of like, okay, I know what I'm
Yeah.
doing and I know how to do this now and I know what to expect. And so it's very, very helpful.
Good. I'm glad that you thought that. I mean, depositions when, when I'm getting deposed as an expert, I always dread the deposition because the attorneys will keep you there for hours and
Yeah.
hours and hours. And then let's just say the case doesn't settle and you've got to go to trial and you're like, oh my God, I've got to do this again. I
Yeah.
can say trial is probably I would rather go to trial than be
Hmm.
deposed because at trial, remember, they've got a jury, and when you're
Yeah.
getting deposed, it's your lawyer, and their lawyer, and
Yeah.
maybe somebody else's lawyer, right? Because sometimes you'll have anesthesia lawyer or the hospital lawyer and the physician or midwife lawyer, and so they can't act like an idiot. They don't want to act like an idiot. They want to act like the nice guy when they've got a jury sitting in front of them that's going to
Yeah.
decide who
Good
where
point.
this case is going to. What I look for when I'm doing these cases is, did the nurse or did the midwife practice within the standard of care, which means that they are practicing what a reasonable and prudent nurse or midwife would do. And all the examples that I gave you today, I would say helps you to practice within the standard of care. So I would just say keep on doing what you're doing with good communication, dragging those physicians and midwives back to the bedside to do some huddles that everyone's on the same page. respecting the care and support that the doula brings in, and
Mm,
you can't over communicate with your patients.
mm,
I can say this, state by state, there are certain states, and I'm not going to mention which ones, that I would probably run to the next state before I would allow them to touch me in an obstetrical. Like, it seems like there are just pockets of the United States that I'm like, hmm,
scary.
how is this?
Hmm.
So not all units run the same. And so I think that what would be really fun is that if we got some crowd participation on,
Yeah,
like,
let's do it.
what the culture is, or what's going on in their unit, or is this provider just cutting episiotomies and not saying anything. Like, I think those would be really insightful comments, because if they
Yeah.
have a question, probably 5,000 other people have the same question.
So next season, we're going to have you back. And so if you have a legal question or a legal scenario, everything will be anonymous. I'm going to leave in the show notes down below two things. One is a quick form for you to fill out. And two, you can send in an actual voice note and we'll play the voice note and answer the actual, like, you get to be on the pod. And so we have both of those capabilities. Check the show notes down below, and then we will come back and answer your burning questions. Because I do think that, like, it's one thing to have this shorter conversation. And I think the tips that you gave are so practical and helpful and help regulating our nervous systems. And I've been to whole legal conferences for like 3 days straight of all the different ways and documentation tips and all of that. And so if you want it, let us know what you want us to focus on. And then we'll continue this conversation so that, one, we can protect our license, even though I don't love that terminology, but that we can just settle in. Because if anything, what I want for you is to be living your best life, to be able to practice in a way that is free, that is open, where you can offer yourself and offer your care without living in such fear. We know that also fear is not good for our nervous systems, it's not good for our decision making. And so to really live in that freedom as you go forth and care for your patients and ultimately help our patients have safe outcomes within the realm of autonomy over their body and their choices. Thanks for spending your time with us during this episode of Happy Hour with Bundlebirth Nurses. If you like what you heard, it helps us both if you subscribe, rate, leave a raving review, and share this episode with a friend. If you want more from us, head to bundlebirthnurses.com, subscribe to our newsletter, or follow us on Instagram. Now it's your turn to take what you learned today, apply it to your life, and continue to build your communication skills at the bedside, encouraging those providers to come talk to your patient and do those debriefs, especially in your harder cases. We'll see you next time.